Hello Medicos, good day to all of you. This is Dr. BK for you and today I will be discussing about the large intestine, and in the large intestine I will be concentrating much on the caecum and appendix, and then I will discuss about the inferior mesenteric artery, which mostly supplies the part of the large intestine. Now, our learning objectives for today with respect to large intestine will be a short introduction followed by the extent and location. So, how far the large intestine extends and where actually it is situated. So, what are the cardinal features? Features which are specific to the large intestine. Then of course the location relations and the various types of caecum, followed by that same way about the appendix. Then applied aspects with respect to the caecum, appendix and the large intestine as a whole. Followed by that I will be discussing about the inferior mesenteric artery, its origin, course, branches. Now, the large intestine is also called as the gut. Starts from the ileocecal junction to the ano-mucocutaneous junction of the anus. From the ileocecal junction to the mucocutaneous junction, that is up to the middle 1/3 of the anal canal, or the upper 2/3, up to the middle 1/3 or the upper 2/3 of the anal canal is the extension of the large intestine. So to just name the parts of the large intestine, it starts with caecum and the appendix, followed by that ascending colon, transverse colon, descending colon, sigmoid colon, rectum, followed by that, and it ends as the anal canal. Only the upper 2/3, because the lower 1/3 is actually from the skin derivative from the ectoderm. It also shows two flexures, which is called as the hepatic flexure or the right colic flexure, the left flexure or the splenic flexure. So the total length is 1.5 meters or 6 feet, whereas the length of small intestine is 6 meters or 20 feet. So it is almost just the 1/3 length of the small intestine. So what is colon? From the caecum to the rectosigmoid junction, in front of the middle of the sacrum. So colon refers to all those parts which end with the term colon: ascending colon, transverse colon, descending colon and sigmoid colon. So, if you look at the development of the midgut, the large intestine, it is partly from the midgut and partly from the hindgut. Up to the right 2/3 of the transverse colon, it is actually developed from the midgut. From the left 1/3 of the transverse colon to the descending and the sigmoid colon, and of course the remaining rectum is actually a hindgut derivative. The rectum lower part anal canal is actually a derivative of cloaca. So cloaca is nothing but that part of the hindgut which is below the opening of the allantois. The allantois is actually a primitive excretory organ. which is very active in case of the apes. The greater part of the large intestine is fixed. It is retroperitoneal, which is your ascending colon, descending colon, and your rectum. So your transverse colon is mobile, it is not fixed. It has its own covering, which is the transverse mesocolon. Same way the sigmoid colon has its own sigmoid mesocolon. Again, that is a mobile part. So except the transverse and the sigmoid colon, which have their own peritoneal folds, the most part of the large intestine is fixed against the posterior abdominal wall structures. Roughly, if you see the shape of the colon, it is inverted U shape and it contains the coils of intestine within the limbs, whether it is the two vertical limb or the transverse limb of the U. It contains within it the coils of small intestine. So your coils of jejunum and ileum. So as I told you, the U shape is mainly formed by the two flexures, which is the hepatic flexure and the splenic flexure, the right and the left colic flexures. So now coming to the cardinal features, whenever tell me the three cardinal features of large intestine means, immediately what should come to our mind is the three features, which is the tinea coli, presence of tinea coli, which you see here, the muscular bands. The next is presence of the whole gut tube is actually bulged out laterally on either side, which is called as the sacculations or the ostrations. Then you have fat-filled pockets throughout the length, which is actually called as the appendices epiploicae. Okay, so appendix means an outgrowth. So epiploicae, which is fat-filled outgrowths or pockets, which you see here. Tinea coli, appendices epiploicae, and sacculations and ostrations. This bulging like this you see, which is the most striking feature of the large intestine. Interiorly, if you look at it, there is absence of villi. The products of digestion, after it is absorbed, only the unabsorbed products enter into the large intestine in the liquid state. This is actually converted into a semi-solid state by the absorption of the water content. Almost 500 ml of water is actually absorbed from the large intestine. From the stomach to the large intestine, the time taken by the food, the digested material to reach the large intestine is around 6 hours. By that, it is also called as the gastric ileal reflex. Through that, what happens? It almost takes here, and from here, what happens is from the undigested material, the vitamin B is actually synthesized by the flora in the gut, by the putrefaction of the bacterial action. So no brush border or villi or microvilli is not present. Mainly what you see here is the presence of crypts, intestinal crypts, deep indentations you see here, crypts of libercule. That is the main thing. Then here you are able to see some shaded parts throughout the epithelial lining. They are actually the goblet cells. They are the goblet cells. Unicellular glands. They are actually called as mucus secreting cells, which are unicellular glands. So absence of villi, crypts. You see the intestinal crypts of libercule with the goblet cells, and blood supply is mainly through the vasa longa and brevia. So in case of small intestine, we call it as the vasa recta. Here the straight Vasa recta gives vasa longa and brevia. Longa actually supplies the outer two-thirds of the wall of the colon, whereas the vasa brevia supplies the inner one-third. So they mainly arise from the branches of the superior as well as the inferior mesenteric artery. From there, after forming arterial arcades, then they give straight vessels which gives rise to vasa longa and brevia. They supply in front and behind the gut as the anterior and posterior branches. Okay. Now, what are actually tinea coli? They are condensation of the longitudinal muscle. You know the gut wall, the structure of the gut wall consists of mucosa, submucosa, muscularis externa, and the outermost covering what you see here is the serosa. So the muscularis externa has got an inner circular layer and an outer longitudinal layer. The outer longitudinal layer, in spite of surrounding the whole gut, it is concentrated in three places with respect to the large intestine or the colon especially, and that is called as the tinea. They are tinea libera, tinea momentalis, and tinea mesocolica. So the tinea libera, you see it on the anterior surface, whereas for the transverse colon, this tinea libera will become or will be seen on the inferior surface for the transverse colon, whereas in the ascending and descending colon it is seen on the anterior surface. The next is actually the tinea momentalis seen on the posterolateral surface. Tinea momentalis can be seen on the posterolateral surface. But what happens is, in case of the transverse colon, it is seen on the superior or upper surface. The next is tinea mesocolica, which is seen on the posteromedial surface. Okay, so that goes to the inferior surface with respect to the transverse colon. So in transverse colon, what happens is the tinea libera is inferior, anterior-superiorly the tinea momentalis, and posteriorly what you see is the tinea mesocolica. All these three tinea converge at the base of the appendix. So the appendix is devoid of tinea. Same way the rectum is also devoid of tinea, because these tinea they merge beyond the sigmoid colon. Okay. So that is what in sigmoid colon tinea libera and momentalis, libera and the momentalis fuse anteriorly, whereas tinea mesocolica forms the posterior band. So the tinea is absent in case of the appendix and the rectum. The next cardinal feature what we are seeing is the circulations or hostrations. Why actually this lateral bulging has taken place is because the total length of the colon, as I told you, it is 1.5 meters or 6 feet, whereas the length of the tinea is shorter than that, which will be around 5 feet. So a shorter tinea, when tries to actually, what happens is enclose the longer gut tube, you get this lateral bulgings or outpocketings. Okay, so just to the shorter tinea which is lesser than the whole length of the colon. So in between this you see the grooves or sulci. Then you see fat-filled pockets, which is actually called as the appendices epiploicae, mostly seen along the descending colon and the ascending colon. You don't see that in the caecum appendix and sigmoid colon. Appendices epiploicae, these fat-filled pockets are absent in case the caecum appendix and the sigmoid colon. So now we will come to the caecum. The caecum is the starting point of the large intestine or the colon, It is also called as a blind sac. One end is blind, dead end. It is called as cul-de-sac. The blind sac, you call it as a cul-de-sac. C-U-L-D. It is called as a cul-de-sac. The breadth is more than the length. One of the organs where the breadth, the transverse measurement is 7.5 centimeters more than the vertical measurement. Now, one more organ which you can tell, for example, is the prostate gland. That also has the transverse measurement which is more than the vertical measurement. Situated in the right iliac fossa, which is bounded by the transtubercular plane above and the right lateral plane medially. Now, basically 4 types of cecum we come across in human beings. So, first type is the fetal type. The cecum is somewhat conical and appendix arises from the apex of the cecum. The next type is actually the quadrate type or the infantile type. So, it is somewhat quadriangular and the base is actually has a sulcus or indentated. From that the cecum, the appendix arises. The next is the most common type. Majority of the people have this, called as the adult or the normal type. You also call it asymmetrical because right sac is larger than the left sac. Cecum is 2.5 centimeters below the appendix is 2.5 centimeters below the ileocecal junction. The next type is again exaggerated, where the right sac is very much large and the left sac is, you see a very small left sac, that itself is not seen here. The left sac is completely absent and the appendix is present near to the ileocecal opening. So, based on this you have 4 types: infantile type, fetal type, quadrate type and exaggerated type. Next, coming to the relations of the cecum. So, anteriorly the coils of the intestine will be present when the cecum is empty, and the greater momentum which will be hanging from the greater curvature of the stomach, they form the relations, and more anterior to it is the anterior abdominal wall. Posteriorly it is resting on posterior abdominal wall muscle, psoas iliacus muscle covered by fascia, iliopsoas fascia. Then between the fascia and the muscle you have femoral nerve, lateral femoral cutaneous nerve, genitofemoral nerve. All these are behind the cecum. So they form the posterior relations of the cecum. The base of the cecum actually rests on the inguinal ligament. Okay. Below it is related to the inguinal ligament. Above it is continuous with the ascending colon and it is covered with peritoneum in front and sides. So actually cecum can be considered as an intraperitoneal organ because it is covered with peritoneum both anteriorly and posteriorly. Coming to the cecal recesses, we all know what are peritoneal recesses. They are pockets of peritoneum because they are raised by the folds. When a fold of peritoneum, mostly because any blood vessel it raises, then you get a small recess or space which is actually called as the cecal recess. We have the superior cecal recess, which is mainly found by the anterior cecal fold, bounded anteriorly by the anterior cecal fold which transmits the anterior cecal artery. Inferior cecal recess. Inferior cecal recess is bounded by the inferior cecal fold or the ileocecal fold, which is no artery is present in that fold, so that is why it is actually called as the bloodless fold of Treves. Bloodless fold of Treves. Behind the cecum, what you see is the retrocecal recess, and the appendix is usually seen behind the cecum with the retrocecal recess. That is about the cecal recesses. Next, coming to the interior of the cecum. So, in mucus, you are able to see that the mucus is actually thrown into folds. You see two orifices. One is the ileocecal orifice, and other one is the appendicular orifice. This is actually guarded by a valve, ileocecal valve, which is formed by the reduplication of the mucosa, submucosa, and also the circular muscle. It has got an upper lip and it has got a lower lip. Two lips the valve has, and the lower lip is actually called as the frenula. They meet at the ends, forming the frenula. The surface projection on the surface, if you want to mark on the anterior abdominal wall, the ileocecal orifice, it is the junction of the transtubercular plane and the right lateral plane. Transtubercular plane and the right lateral plane. Now, contents from the ileum is emptied into the cecum, but the reverse flow is not allowed. It does not allow contents from cecum into the ileum. The next orifice, 2.5 cm below that, you see the appendicular orifice, where the base of the appendix opens into it, and that is guarded by a valve which is called as the valve of Gerlach. Okay. So, appendicular orifice is guarded by a valve which is actually called as the valve of Gerlach. Coming to the blood supply and lymphatic drainage, anterior and posterior cecal arteries, which are again branches from the ileocecal arteries. So, cecal branches of ileocecal arteries gives anterior cecal and posterior cecal arteries. Posterior cecal artery will again give appendicular artery to the appendix. Veins correspond to the same name, anterior posterior cecal vein. They will drain into the superior mesenteric vein and naturally to the subsequently to the portal vein. Lymph nodes, ileocholic nodes, they drain actually to superior mesenteric nodes. The ileocholic nodes, they drain into the superior mesenteric group of pre-aortic nodes. Nerve supply of sympathetic as well as parasympathetic. Sympathetic from T11 to L1 segment. From there it goes to the superior mesenteric plexus, and then postganglionic fibers supply it. Parasympathetic is vagus. So for gastrointestinal tract, you can simply write vagus parasympathetic. Applied anatomy of the cecum. It acts as a guide to surgeon in locating the intestinal obstruction, which means if the cecum is loaded with contents, then there is an obstruction in the large intestine. If the cecum is not loaded, it is empty, then the contents, the digested material has not reached the cecum, which means the obstruction is in the small intestine. So, if at all we cannot locate the site of obstruction, first what happens, the surgeon tries to examine the cecum, whether it is loaded or empty. If it is empty, then the obstruction is in the small intestine. If it is loaded, then actually it is not in the small intestine but in the large intestine. So a distended cecum, as I told you, a loaded cecum. Twisting of the colon, especially the cecum, is actually called as the volvulus. Sometimes what happens is the ileum will get herniated into the cecum. The ileum might get herniated into the cecum. So a gut, inside a part of the gut, that is called as the intussusception. Okay. So the ileum is actually herniated into the cecum or ascending colon, which is actually called as intussusception. Volvulus, intussusception will all produce intestinal obstruction. If at all it is chronic, it might also lead to gangrene formation. if the blood supply is severely compromised. Next, we will come to the appendix. With respect to the appendix, it is called as vermiform appendix. It is like a worm, a small worm, that is why it is called as the vermiform appendix. Vestigial structure, so not functional in case of humans. Nothing goes into this for digestion. So mainly in ruminating animals or rabbit, for cellulose digestion, this is very active, which has become vestigial in humans, but it creates a lot of problems when it is infected. It is also called as the abdominal tonsil. It gets inflamed mainly because of infections. Aggregated lymphatic follicles are seen inside the wall of the appendix. That is why it is also called as the tonsil of the abdomen, narrowest part of the GI, gastrointestinal tract. The average length is around 9 centimeters. 20 centimeters is very extreme length. 9 centimeters. So if it is retrocecal and if it is a very long appendix, then you can see sometimes even near the right colic flexure, high above, that is below the liver, sometimes you can locate the appendix. So presenting parts, it has got the base attached to the posteromedial surface of the cecum 2 cm below the ileocecal junction, and it's guarded by an opening, the appendicular orifice, the valve. So the tinea converge at the base. The three tinea, tinea libera, tinea mesopolica, and tinea omentalis. The appendix lacks the tinea. There is no tinea, there is no appendices epiploicae, there is no hostrations. Next to the base, we have the body, which is slender, long, mobile part. Then you have the tip of the appendix, which is least vascular. Okay, because the fold of the appendix, mesoappendix, fails to reach the tip sometimes. So if there is no peritoneal fold reaching the tip, then the blood vessels also cannot reach the tip. So that is why the tip of the appendix is least vascular. So appendix may acquire many positions. The most common position is the retrocecal position. Okay. But other positions also we will try to see. So first you are able to see it lies parallel to the ascending colon, paracolic. So that is what is called as paracolic, and it assumes the 11 o'clock position of the clock. 11 o'clock position. Most common type is the retrocecal position, which is the 12 o'clock position behind the cecum. Then what you have is the splenic type, which actually is the 2 o'clock position. It is directed upwards and medially. It might be pre-ileal or post-ileal. The pre-ileal again is a very dangerous position, because if at all, if the appendix gets inflamed, especially the pre-ileal type, then it might infect the peritoneal cavity, general peritonitis. It might lead to that. Okay, that is about the splenic. Then 3 o'clock position, transversely when it is facing the sacral promontory, it is called as promontoric position. Then it is present towards the pelvic brim and sometimes might be related to the uterus or the right uterine tube in case of females. So that is the 4 o'clock position. Then ultimately we have one more inguinal position, which faces downwards, exactly vertically downwards, which is the inguinal position, of the 6 o'clock position. So 11 o'clock, 12 o'clock, 2 o'clock, 3, 4 and 6. These are the various positions you can encounter cecum. So it has its own fold of peritoneum. The mesoappendix, this is actually the ileocolic fold, which is the bloodless fold of the treves. The mesoappendix might fail to reach the tip of the appendix, and this is derived from the posterior layer of mesentery of the ileum, the mesoappendix. It is mainly supplied by appendicular artery, which is a branch of inferior division of ileocholi. Superior division of ileocholi, inferior division of ileocholi gives the appendicular artery. This appendicular artery in turn gives a recurrent branch to supply the caecum veins, then into superior mesenteric. Lymphatics, same ileocholic nodes, superior mesenteric nodes from there. Nerve supplies, sympathetic is from T10 segment of spinal cord through the splanchnic nerves. T10 segment through the splanchnic nerves, they supply the appendix. So because of this T10 innervation, umbilicus has that same T10 innervation. So referred pain of appendicitis is sometimes the umbilicus. Parasympathetic is by vagus nerves. So inflammation of the appendix is actually called as appendicitis. It might manifest as vomiting, fever, you have temperature or vomiting, pain in the umbilical region initially, but what happens gradually settles into the right iliac fossa. Mainly acute appendicitis is because of obstruction due to a fecolith or an edema. So, now McBurney's point, this is actually called as the McBurney's point, or it is called as the spino-umbilical line. From the anterior superior iliac spine to the umbilicus, you draw a line. Then you keep a point at the junction of medial 2/3 and lateral 1/3. That point is actually called as the McBurney's point. Maximum tenderness is felt at this McBurney's point during appendicitis. Okay. So rigidity will come. The anterior abdominal walls might undergo spasm because of the involvement of the peritoneum. So maximum tenderness is felt at the McBurney's point. Now, certain tests to actually see whether the appendicitis is involved or not, appendix is involved. The psoas test asks the patient to lie to one side and then extend his hip. The right hip, if you extend, then naturally the inflamed appendix will irritate the psoas muscle. The person feels pain while extending his right hip or right thigh. It's called as psoas test. Then you have one more test which is actually called as the obturator test. It is related to the obturator internus muscle. So inflammation might also irritate this muscle, pain during flexion and medial rotation of the right side. This is called as the psoas test and obturator test. So removal of appendix is actually called as appendectomy. Okay. So if it is chronically inflamed and it is painful situation unbearable, or it is recurring again and again, then appendectomy is actually advised. So a quick look at the other parts of that: ascending, descending, transverse and sigmoid colon. So the length is actually given here, of which the transverse colon is the most lengthiest. Peritoneum, it is retroperitoneal, so only front and sides. This is also retroperitoneal, this is intraperitoneal, this is intraperitoneal. So relations: in front you have the coils of intestine both for the ascending and descending colon, and greater omentum for the transverse colon. Posteriorly, it is related to the psoas major muscle, iliacus, right kidney. All these forms the posterior relations of the ascending colon. Descending colon, again left kidney, left iliacus, femoral, genitofemoral nerve. Transverse colon, behind it will be related to the pancreas, second part of duodenum, and coils of intestine. Sigmoid colon, it has first part runs anteriorly towards the left, second part is actually oblique, transverse, and then third part is actually oblique. Below the third part will be related to the coils of intestine, and below it will be related to the left urinary bladder, laterally to the external iliac vessels. It has its own peritoneal covering, which is your sigmoid mesocolon, inverted V shape peritoneal fold. So coming to we have seen about the caecum, appendix, and some general features or cardinal features of the large intestine, and about the general features of the ascending, descending, transverse, and the pelvic or the sigmoid mesocolon. Now coming to the inferior mesenteric artery, it is actually the artery of hindgut, supplies the left to 2/3 of the ascending transverse colon, then whole of the descending colon, sigmoid colon, rectum, up to the middle 2/3 of the anal canal. Okay, up to the pectinate line of anal canal, that is the middle 2/3. The inferior mesenteric artery supplies. So ventral branch of aorta at the level of L3 vertebra, third lumbar vertebra, ventral branch. Okay, arises retroperitoneally, the posterior abdominal wall, runs to the front and towards the left side, passes downwards and to the left, and then crosses the left common iliac artery. So it is crossing the left common iliac artery and then enters the pelvis and ends by supplying or ends as supplying the highest sigmoidal artery. So before that it enters into the sigmoid mesocolon, accompanied with its vein, the inferior mesenteric vein. So that is the sigmoid mesocolon, where it enters into this peritoneal fold. So as I told you, it terminates as the superior rectal artery. So the branches of the inferior mesenteric artery will be mainly the left colic artery. So the left colic artery, on reaching the colic flexure, left colic flexure divides into a ascending and a descending branch. The ascending branch anastomoses with the right branch of middle colic artery. So ascending branch anastomoses with the right branch of middle colic artery. The descending branch will anastomose with the highest sigmoidal artery. With the highest sigmoidal artery, the descending branch of the left colic artery. Sigmoidal arteries are usually 2 to 3 number. They divide into ascending and descending branch. And lowest sigmoidal artery anastomoses with the superior rectal artery. Lowest sigmoidal branch will anastomose with the superior rectal artery. So left colic artery, sigmoidal artery. Now coming to the superior rectal artery. Continuation of the inferior mesenteric. The superior rectal artery is actually a continuation of the inferior mesenteric artery. So runs in the mesocolon. The superior rectal artery, you are able to see it runs at the level of S3 vertebra, divides into right and left branches. Superior rectal artery divides into right and left branches. Then from the submucosal plexus, they break into plexus the submucosa. They pierce the muscle of the rectum, break into submucosal plexus, as I told you, and anastomose with the middle rectal artery. Then from there, vessels pass along the anal columns to anastomose with the inferior rectal artery. Okay. The superior rectal artery anastomoses with the middle rectal, and then after that, it also anastomoses with the inferior rectal artery. So straight vessels, as I told you, in the anal canals are anastomosed with the inferior rectal artery. Superior rectal artery anastomosed with the middle and inferior rectal artery. So if you look at the branches, whether from the right superior mesenteric, it forms arterial arcades, and they form a continuous arcade-like structure, one large arcade-like structure which is called as the marginal artery of Drummond, found to the anastomosis of ileocolic, right colic, middle colic. Okay, that is the marginal artery of Drummond. Throughout you can see that, so that the blood supply is not interrupted. So it is formed by the anastomosis of ileocolic, right colic, middle colic, left colic, highest sigmoidal and superior rectal arteries. From there, vasa longa and brevia, this we have already discussed in the initial part of our class itself. So they supply the outer 2/3 and inner 1/3 of the muscle coat of the rectum, gut tube as such. Now, if the connection between the highest sigmoidal artery and the superior rectal artery is not established, then it is actually called as the critical point of Sudak. Okay, so between the lowest sigmoidal and superior rectal, if this connection is not there, it is called as critical point of Sudak. But now recent versions, they don't accept anything such like this critical point of Sudak is present. Anyway, the blood supply is established. Inferior mesenteric vein, you are able to see, starts as small veins, continuation of superior rectal vein. Left common iliac vessels, it crosses and continues as the inferior mesenteric vein. The inferior mesenteric vein passes by the side of duodenojejunal flexure, medial to the ureter, lateral to inferior mesenteric artery. So after passing the right of duodenojejunal flexure, terminates into the splenic vein behind the body of pancreas. Okay. Inferior mesenteric vein. Just you have to simply see this picture diagram and explain. Starts as small plexus, continues as the upward continuation of superior rectal vein, passes by the side of the duodenojejunal flexure and terminates into splenic vein behind the body of pancreas. So the tributaries correspond to branches: sigma highest sigmoidal vein, left colic vein, superior rectal vein. So sigmoid volvulus. So twisting of the sigmoid colon onto itself, because it is mobile due to the presence of the sigmoid mesocolon. So twisting followed by that obstruction is called as sigmoid volvulus. This is inflammatory bowel syndrome or Crohn's ulcerative colitis or Crohn's disease. So you see ulcerations throughout the length of the large intestine. So the exact cause is not known, and there is no established cure or something. So only the symptoms can be relieved. So symptoms may be diarrhea, bleeding, excessive gas, pain. All those things are symptoms of the ulcerative colitis or Crohn's disease. Hirschsprung disease or congenital megacolon. So we call congenital megacolon because it is very large and expanded, but actually the problem lies in this narrow part. Because this part has narrowed down, the proximal part is enlarged, but this actually the enlarged part is normal. Distal to that part which is very much diminished in its lumen, because of the absence of mesenteric plexus. So the mesenteric plexus, they fail to form because the neural crescents fail to migrate into these areas, and that leads to congenital megacolon or Hirschsprung's disease. Then you have diverticulitis or diverticulosis, which is small pockets mainly formed due to pressure due to passage of fecal matter or gas. It might lead to diverticulitis or diverticulosis. Diverticulosis As I told you, perforations or something like that, small openings along the colon. So that is about the applied anatomy of the gut, large intestine or the colon. So thank you very much for your patient listening. We will meet again in one more session.